Hello, hello, welcome. Welcome, everyone. So glad to have you join us. Hello to everyone.
Hi, folks. Good morning, good afternoon. We will get started just on the hour. Thanks for joining.
In the meanwhile, if you'd like, go ahead and put your name and organization in the chat and just let us know where you're coming from. That would be great.
I'm called Agnes Kovia.
Hi, Agnes.
I work with Ministry of Health Uganda. And I work as a biomedical engineer in Health Infrastructure Department. Glad to be with you today.
Thank you so much for joining us, Agnes. We look so forward to hearing your comments later on. All right, great. We have some more people in the chat who are letting us know, coming from CDC. Hi, Matt, and from Guatemala, from the Norwegian Church Aid. Yes. Hello, hello. WHO Afro. Welcome to you all. Hello, hello. Thank you. Go ahead if you'd like. Just go ahead and put your name. Yes. Hi, Doris. Put your name in the chat and just say hello, where you're from. We're going to get started in just a few more minutes. We have a message from our Spanish language interpreter, Heidi. Hi, Christine from Kenya.
It's fun seeing familiar names pop up.
Yeah, it's good to see people that we know. Good to see new people too. Oh, I know this gentleman, Ron Denham.
Hi, Ron.
Hi there.
Greetings. Great. We'll get started here in 2 minutes. I know we've got quite an agenda for us, so we do want to start promptly.
Mm-hmm. Hello. Oh, that's Agnes. Yes. Thank you. Putting it in the chat. Thank you.
All right, Jane, I'm just going to pull up the slides for you.
Mm-hmm. All right, Lindsay, just give me the word when we are ready.
All right, if you want to go ahead and get started, let's do this.
All right. Well, good morning, good afternoon, good evening to everyone. I want to welcome you all to the Washington Healthcare Facilities Community of Practice Initiative. We are so very glad you could join us today. I want to introduce myself and our team. My name is Joanne McGriff. I'm an assistant professor within the Department of Global Health within the Rollins School of Public Health here at Emory University. And also I'm core faculty within the Center for Global Safe Wash at Emory. I have with me Lindsay Denny, also from the Rollins School of Public Health, as well as UNICEF, and Haley Elling from World Vision. We also have several members of our Community of Practice Steering Committee. So these are the folks who help us think through and implement these webinars. Several of these committee members are present in the virtual audience, as well as our great team of interpreters who are going to assist us today with Spanish and French-speaking participants. And before I leave from that point, I want to please go ahead and encourage you to choose your language of choice in the bottom toolbar of Zoom. We are asking you to do that now, and especially those of you who are listening in English, to please choose English, as one of our speakers, actually one of our panelists, will deliver their presentation in Spanish as their primary language. So we just want to make sure that everybody's chosen their preferred language so that there will be an easy transition. As always, today's session comes from the community, whether discussions among the Community of Practice Steering Committee members, topics being raised at important global and local gatherings, or sometimes issues that come up from the ground up, if you will, from our partners. Today, we turn our attention to the built environment of a healthcare facility. So what do we mean by this? How does WASH fit in with other larger issues of healthcare infrastructure? And who are the different types of partners we need to know and to work with in order to make good decisions about whether it's new construction or retrofitting existing facilities? So we're really pleased today to have a set of multidisciplinary speakers and panelists who will talk to you about the built environment healthcare facilities and some of the major issues that we should keep in mind when we think about WASH and infrastructure. So please keep your questions and reflections close by. Be prepared to engage with our distinguished panel during the discussion section. So before we get started, I do want to make sure that we take a few moments to welcome those who are new to the Community of Practice meeting and provide some background on who we are and what we do. So again, we are an action-oriented learning platform that brings together the WASH and health communities to focus on policy, evidence, and practice in WASH and healthcare facilities. Our goal is to connect the expertise and experience of our partners and colleagues to the members of the WASH and health community who are interested in taking action in WASH and healthcare facilities. We've created this platform as well as our newsletter and our webpage to share resources with the WASH and health community. And our goal for each live session is that participants walk away with tangible information that will allow you to take almost immediate steps to advance the improvement of WASH and healthcare facilities. Next slide. I also want to remind everyone of the guiding principles of the Community of Practice, so you know where we're coming from in these webinars or when you see our newsletter. We firmly believe that WASH is a fundamental prerequisite for quality care within a healthcare facility, that there can be no effective infection prevention and control, or IPC, without adequate WASH. We believe that this issue around WASH in healthcare facilities is a solvable issue, but it will require multiple stakeholders, sectors, systems to work together in order for us to see improvements. And that the Community of Practice is really open to all of us who want to learn and share about WASH in healthcare facilities. We welcome a diversity of perspectives. And so whether you are a seasoned expert in WASH in healthcare facility or someone for whom this topic is new, we definitely welcome you and welcome your perspective. So we have some news and updates to share. Each time we meet, we try to feature a success story. And what we mean by that is something good that's going on in WASH and healthcare facilities. And so please keep an eye out. If you have a story to share, please go ahead and do that. Send us a quick email. But for this meeting, we want to talk about WEFTA, W-E-F-T-A, Water Engineers for the Americas, for submitting this success story regarding a health center WASH project in Mbinga, Diocese of Tanzania. The program is in a few phases, and the first phase was just completed between May 2022 and August 2022, and it included water source improvements, some line construction, and watershed protection. So again, we think success is across a range of different kinds of activities within WASH and healthcare facilities. So we thank WEFTA for sending us this update, and we again encourage anyone else who wants to send or highlight some sort of improvement or advancement in WASH and healthcare facilities, go ahead and send us a note so that we can highlight it in our meetings or at least in our newsletter. Other good news, next slide. In the WASH and healthcare facility world includes the release of the new Joint Monitoring Program, or the JMP report on WASH and healthcare facilities. Many of you may have already seen this. Those of you who have not, please go ahead and take a look. It covers progress on WASH and healthcare facilities between 2000 and 2021. And since the last report, JMP has been able to now provide estimates on hand hygiene. If you recall, it was very difficult to get those estimates in the last report. And so now we know that half of healthcare facilities do not have basic hygiene services. In terms of water services, we know 1 in 5, these are updated estimates, 1 in 5 healthcare facilities do not have basic water services. And then 10% of facilities have no sanitation services. So in terms of impact, you see the numbers expressed in terms of the billions of people who lack first basic hygiene, 3.85 billion, those who lack basic water, 1.7 billion, and then 780 million who have no sanitation service at all. So please keep take a look, keep an eye on this report and see how the estimates are changing and being updated. And again, pay close attention to your region in terms of how things are moving for Washington healthcare facilities. So next slide. Want to take a few minutes because we are really rounding the corner of our first year implementing the Washington Healthcare Facility Community of Practice, this COP. And so we'd like your feedback on how to make year 2 even better. For those of you for those who are not able to join us today, we're going to send out this very same poll in our newsletter. So if you complete it today, you won't have to complete it again if you see it in the newsletter, but we just want to take this moment while we're all gathered here to look at some questions together and sort of get a sense from you how this is all working out. So let's go ahead and get up the poll up. Thank you very much. A couple questions for you, if you don't mind, please go ahead and filling it out. Have you been working on any Washington healthcare facility projects between 2021 and 2022 over this last year? Do you have plans to undertake Washington healthcare facility projects in the next year between now and 2023? Has the community of practice provided resources? And there's a few examples here which you have supported that have supported your Washington healthcare facility activities directly. And then looking ahead to year 2, how would you like to engage with the COP? We continued doing webinars this past year because of the great feedback we got 1 year ago this time, but we just want to make sure we're on track and really serving this community well. So go ahead, if you will, take another 2 minutes or so, respond to this, and then we'll take a look at the results together.
And if you have any thoughts, feel free to put them in the chat about what could make this community practice more effective for you. We certainly want to serve the needs of the community, and this is the best way for us to figure that out. Thanks.
Mm-hmm. Take another minute or so. Go ahead. If those of you just joining, we're completing a poll. So if you just look across the bottom, just quickly want to get a pulse check. Thank you so much, John, for the comment. Again, we encourage you to complete the poll and also put any comments in the chat of how we can continue to improve this community of practice, how we can deliver good information, and in what ways. So thank you for that. Take another 20 seconds. Okay. I'm unable to follow the whole chat, John. Appreciate it. Okay. All right, I think we can take a look at some of the responses here. All right. Have you been working on projects over the last year, 2021, 2022? Good majority of you all, 85% almost. Yes, so that's really great to hear that there are projects underway. Do you have plans to undertake projects now through 2023? Wonderful, 76% of you say yes. 4% say no, and 20% are not sure. So there could be a possibility that you could maybe take on a project or not. So that's really good to hear that. Has the Washington Healthcare Facility Community of Practice basically supported you in your activities? Good, great to hear. 66% of you think so, and 34% say no. And again, if you all want those who are in the no category, feel like there's something that we could do to help support some of your work, go ahead and put some comments in the chat or private chat, either one of us that's on the learning team here, and we'd be happy to respond and take up some of your suggestions. And then the last question, how would you like to engage? And it looks like, yet again, 90% feel that webinars are a good way for us to engage with you as a community, but we see a real strong group also feels that the roundtables or discussions would be a nice way to do this, as well as keeping up with the newsletter and other email resources. So thank you so much. I will say the 44% who appreciate the pre-recorded videos, we are seeing a real uptick in our YouTube videos, and we really are really pleased to see that, because we know sometimes folks can't make the live sessions. So it's really great to know that when we reproduce the short videos or some of the summary videos, that people really do engage with that. So thank you so much for that, and we'll continue to help keep that out there. And then again, we're continuing to ask you to put in the chat any other comments that you'd like to make about making improvements over the next year. All right, without further delay, I want to shift our attention to our main speaker, Mr. Luis Fedor, who comes to us from UN Habitat Mozambique, where he is a healthcare infrastructure specialist. Mr. Fedor will set the stage for us in an opening presentation about built environment before we move to our panel discussion. So over to you, Mr. Fedor.
Good morning to everyone. Good afternoon or good evening, depending where you are. First of all, I will make us a brief introduction of myself. I'm a healthcare architect and hospital planner with more than 15 years of professional experience implementing and monitoring simple and complex healthcare projects around the world. I've been working in different healthcare contexts, including Italy, Brazil, Trinidad and Tobago, Portugal, and now in Mozambique. And in the past years, I've been working a lot with ministries of health, improving and increasing the health service with the implementation of healthcare infrastructures. Would like to take the opportunity to congratulate Center of Global Safe WASH for this initiative, and in particular this event. And greet also to all the other participants, and thank you for the opportunity to share my experience, but also learn from the other experts on this field. So I think we can start. I will just follow. I will turn off my camera if it's possible for a bit. Thank you. So I prepare a table of contents where we will look to the what's an infrastructure, healthcare infrastructures, and also what's WASH in healthcare facilities. We will also see what's hospital planning, and that includes strategic planning. And then we will look into the hospital built environment. We can move to the other slide, please. So when we talk about healthcare infrastructure, healthcare is an institution that provides patient treatment, and that can be with specialized health science, auxiliary health staff, and medical equipment. When we talk about healthcare, it's the improvement of health via prevention, diagnosis, and treatment of people. Another definition that we could put, it's an institution that it's built, and I want to underline here that it's built, staffed, and equipped for the diagnosis and diseases of and treatments, medical or surgical, for the sick and injured people. And also the housing during this process. And I would like to take some keywords on this. It's prevention, diagnosis, treatment, also health system being an instrument for care, coordination, and integration. So this, I'm just taking some words so we can reflect on them. And also that healthcare infrastructure provide medical, surgical, psychiatric care, treatment for sick and injured people, provides a setting for education and for clinical research, and of course, different levels of care. We have different levels of care, primary, secondary, specialist, etc. And if we move forward, we will now look to the WASH in healthcare facility. So what's the definition of WASH in healthcare facilities? It's practically the provision of water, sanitation, healthcare waste management, hygiene, and environmental cleaning. We also could include that it's the support supports water, sanitation, hygiene, healthcare, waste management practice inside of the healthcare and preventing, of course, the spread of diseases and infection control. Here also wanted to take some keywords that it's healthcare facility, because previously we were looking to healthcare infrastructure. Now we are looking to a healthcare facility, improving health system by strengthening and health security. Different levels of facilities have different wash needs, and without appropriate wash infrastructure and services, patients, healthcare staff, communities are in increased risk of disease. So going to the second phase of this presentation, I will talk about hospital planning. And in order to understand in detail how we develop a hospital infrastructure, first we have to talk about hospital planning, which comes from a strategic planning. So we can move forward to the next slide. And the term strategic, it was widely used by the military when we want to talk about achieving goals with high level of efficiency or performance. Later on, this meaning, this word, start to be used also by nations and societies and for companies, the strategy of a nation, that we have to consider, especially for the last one, that it's a continuous strategic. So it's the continued evaluation, because when we plan, when we do this strategic planning, of course, plans do not, they can deviate. There are external competitors arising, resistance of society, this involves monitoring goals, the identifying and developing, advancing new strategic priorities. So I just wanted to highlight this continuous strategic step that we have to look when we are planning an hospital. And also to mention that in a broader vision, a health sector of a country or region needs strategic planning. So it requires that those are responsible for the societies to do proper strategic planning to reach objectives at a high level of efficiency and at the lowest possible cost. One of the examples of these strategic plans, it's the pandemic that we observed that affected all humanity. And to achieve those goals and efficiency, the health systems, health sectors needed to do strategic plans to make the successful. So I wanted to bring this to the conversation, to the table, to show how the hospital planning needs require proper strategic knowledge to make the most of the resources and achieve high level of efficiency. If we now move forward, we will now talk about hospital planning. So planning is the forecasting and organizing the activities required to achieve the desired goal. And hospital buildings, we know they differ from other buildings because of their complexity and function. In this way, the hospital planning involves analysis of the health system of a country, which concerns both population and politicians, or politicians in this case. And it's also a social sector, but also economic, and which spends very important amount of society resources. Now we going to see this process of planning an hospital and what's required as an overview. I will briefly, we can move to the next slide, please. I will briefly talk about how that process is done. So to construct an hospital, there's a need for an assessment. Of course, we are planning in a hospital. There's a need of assessment. What type of health we need? Preventative, curative, rehabilitation, any special, or if it's rural, urban. For what catchment population we are looking for: elderly, children, women, specified disease group, we need to do some data collection, disease patterns, demographic, market surveys, and also if we have the funds required for that. And then we have the feasibility study, so financial feasibility, site selection, availability of area for expansion, or areas exposed to natural hazards, soil conditions, accessibility, also availability of infrastructure such as electricity, water, waste disposal in the area, things like that. So these two aspects are quite important when we plan these activities. And I also highlight in red one of the main items when we plan an hospital. It's the design brief, architectural brief, or user brief. People use different names for the same item. And to provide all this assessment, feasibility, and this program of the hospital, there's a need to create a multidisciplinary team, which will include hospital administrators, specialists from various clinical branches, infection preventionists, civil electrical architects, other disciplines of engineers, representative of local bodies, health planners, architects I mentioned before, and also community representatives, can be patient or community advocates, user of equipments, and so on. So this multidisciplinary team as one of the big tasks that it's to develop this architectural brief or user brief. If we move forward, I will go in detail, change the scale. We can move to the next slide, please, and we will look to that hospital planning and the activities behind the construction activities. So we spoke about assessment, feasibility studies, but then the project planning and implementation, this is where the construction happens. We have this document that I was mentioning, the user brief, that it's a document that keeps the project on plan, goal, and purpose. The role of the healthcare planning process is to produce the design brief and guide the outputs as we need. Some of the contents of this document is specifications of functional areas, relationship between those areas, adjacency, specifications on specific drawings and models, specifications on MEP going for mechanical, electrical, plumbing, so water supply, electricity, medical, lifts, specifications on firefighting, policies, procedures to be used, local regulations, standards, best practice, space program, schedule of accommodations, build environment condition and specifications. And so this is why I'm bringing this document, because it's a very valid and important document for all this process. Also, while these activities are running, there's also, when we mention these activities are running, the project implementation, planning and implementation. So when construction is ongoing, there are some activities such as the strategic planning for the facility that can go simultaneous. And what is this strategic planning for the facility? It's for the operational of the facility. So staff planning, additional recruitment, training, staffing, procurement of consumables, drugs, lineal, reagents, instruments, material, food, all of these, housekeeping, and etc. Also, if you want to outsource some of those services, this is where those strategic planning starts to develop in conjunction with the construction and so on. Then those two final items is the commissioning and the shakedown period. So these are parts or items during the hospital planning. We can move forward, and I will talk a little bit more about the user brief. So the user brief we mentioned, there needs to have a team, a multidisciplinary team. It's the function program, space program, but there are two items here that I would like to highlight. One is the safety risk assessment. It's an assessment to ensure that design and construction provides safety delivery of care. Safety risk assessment should be developed, this includes ICRA. ICRA, it's infection control risk assessment. patient handling, movement, and so on and so on. So this document is quite important when we are talking about built environment. The second item or document coming out from this user brief, it's the environmental care and facility functional program, where we have key elements of the physical environment and functional operation requirements. We can move forward. So I spoke about healthcare infrastructure, the definition, also the definition of WASH. We looked at the hospital planning and what's a strategic planning. And now we're going to focus on the built environment on healthcare facilities. We can move forward to the next. And what's the definition then of built environment? It refers to the human-made surrounding, providing the setting for human activity, ranging in scale from buildings and green spaces to neighborhoods and cities that can often include their supporting infrastructure. Another definition, it's buildings. Buildings are one of the most clear elements of the built environment because they physical presence and purpose to protect us against natural or unbuilt environment. Here I also want to highlight some keywords. So designing of a physical space, connection between physical space and social consequences, material, spatial, and cultural product of human labor, protect against natural or unbuilt. So we could look this into two different things. The built environment is made up by physical features. However, when we study it, the built environment often highlights the connection between physical and social consequences. Just as an highlight, healthcare providers aim to make their communities healthier by providing safe, effective, and sustainable health services. It's essential that health services are well planned and organized and based on a community and its healthcare providers' need. So service must evolve in line with cultural expectations, changing practice, and technological advancement. And because the built environment has a profound effect on health, public health research has expanded the definition of built environment to include also healthy food access, community gardens, walkability, and etc. Meaning items of the environment into the built environment. If we move to the next slide, I would like here to look to the built environment in two perspectives. One, it's a broader vision, so the built environment outside of our healthcare facility, and then in a narrow vision, built environment inside of the healthcare facility. So there, know that there are wider determinants of health, or we can call it social determinants of health that play a big role in overall levels of health and well-being. This includes aspects from everyday life, such as natural environment, built environment, local economy, community life, health behaviors, and so on and so on. As an example, the diseases of the 21st century, the chronic diseases, heart disease, diabetes, obesity, asthma, depression, those can be moderate, but how we design this wider built environment. Here, I would like to make just a highlight to build environment. I'm sorry for the noise, but this is also part of the built environment. So as you can see, I don't have the proper conditions on the noise proofing. So moving forward, as a side note, it's important that we have to understand that urban planners, engineers, architects, we have a critical role in public health when we're designing these global ecosystems, natural environments, that it's also part of a built environment of a society. And there is already a shift in the thinking. Let's make people healthier in a closed environment, so in the health facility, but to include a global ecosystem, natural environments, and the community as part of this master planning of a healthcare facility. If we move forward to the next slide, I will talk a bit now about this narrow vision or the built environment inside the healthcare facilities. So here we will look more into a building as a climate modifier. And when we look to that, we look to the comfort. So when we look to a built environment inside of a building, we as architects or engineers, now we look to the comfort that that environment provides. And now, in terms of healthcare facility, those environments and those conditions or those requirements are much wider than a normal building or infrastructure. So we were mentioning, so those key elements of the physical environment and functional operation, they influence on the patient outcome, satisfaction, dignity, privacy, confidentiality, safety, as well as the facility operations. We're talking about systems, building infrastructure systems, circulation, security, wayfinding, acoustics, indoor environment, equipment, and so on. And to ensure that the design and construction provide a proper built environment, safety delivery of care is extremely important to compliant with codes. And of course, we are always talking about different levels of care, different types of facilities, but it's important for code compliance. And actually, this code compliance give us also some other achievements or standards of quality, outcome and expectations. Some of the Ministry of Health or some of the clients that we have, public or private, they go for accreditation, for example. And this is one of the main items. If you don't comply with some codes, with some guidelines, with some standards, the accreditation, then it's compromised. Built environment. So when we talk, for example, about fire penetration, fire detectors, fighting, the temperature, ventilation, humidity, noise control. So all of these are items, they are standardized for healthcare facilities, and they provide even ranges or ratios that help us to design and to plan these facilities. I will just mention some of them so we can see also how the WASH can be incorporated into those items. When we look to the engineering service, so the air condition, that's including the pressurization, that's working a lot with infection control policies, isolation rooms, and so on, the ventilation, the exchange of air in different clinical settings, from treatment areas, operating theaters, to consultation rooms. They have different setting of ventilation or exchange of air, and those are also standardized. Another item, for example, the power outlets, the number of outlets that we need to make functional operating theater or a consultation room, they are different and they are also standardized. And the amount of outlets that we will have connected to the emergency backup system, the lighting, quality of lighting, sanitary and fixtures, medical gas outlets, CCTV cameras, nurse call, security. So I'm just putting here some of the items that are part of this built environment. I mentioned before the fire detection, firefighting, the electrical generators, water treatment, also generation and storage, in some cases the water generation. So all of these items that I mentioned, they are standardized and they are needed for the functionality of a health infrastructure. They also are required in terms of WASH, of course, but they also condition our built environment. One of the compliance requirements to provide safe and quality care is the infection control prevention. So the type of finishes that we will need for different areas. So clinical areas, they have a higher need or requirements of performance comparing to non-clinical areas. And for all of this, I wanted to bring this safety risk assessment. So safety risk assessment, as I mentioned before, it's a multidisciplinary document that does an assessment of the hazards, identify hazards and risks, and then mitigate them in a form of a document. And for this, of course, we need the experts involved in this. But this document, according to the catchment population, to the disease patterns, design of the building. So when we start to develop this safety risk assessment, we already have some kind of ideas of how the project looks like, the adjacency, and this document mitigate any type of identified hazard or risk inside the facility, inside, and I would put also outside. In conjunction with the safe risk assessment, so we have the infection control risk assessment. We have also patient handling and movement, and this is more connected with equipment to transport patients, also to bariatric considerations, for example. So everything that has to do with moving patients inside the facility or outside, it's also described in this document. And this also influences on the built environment. So if we have different or specialized type of equipment to transport those patients, then our built environment, of course, changes. There's also the fall prevention assessment, and this regards of ramps, stairs, handrails, light levels, flooring, patient toilet rooms, also the medication safety assessment, and the behavioral and mental health risk assessment. We know that this sector of health has a particularity on the furniture, fixtures, the security. So I wanted to bring this document, safety risk assessment, and if we move forward, also as part of the built environment, we have the sustainable design, the healing environment. So when we talk about sustainable and healing environments, there's the base evidence that the design can improve patient outcome, staff morale, and visitor experience. So the location, orientation, building layout, natural light, ventilation, all those that impact on the effectiveness and increase efficiency on a building, in this case, the healthcare building. We have to consider this also as part of our built environment. The conservation of energy and water, so conservation measures to infrastructures, the use of renewable energies, green areas, access to nature. So all of this help to reduce also the stress and depression, but at the same time will come and form part of our built environment. And I wanted to highlight that now the sustainable practice in healthcare environments is being widely used and has a great impact also on the functions and behavior. And if we move to the next slide, I wanted also to talk about two other items, that it's disaster preparedness and climate resilience. So the capacity of a healthcare facility to resist, adapt, and recover from climate change and related events. The need of adequate and reliable infrastructure technologies, and this goes also to water, energy, telecommunications, to have redundancy measures to ensure continued safe and effective operation, even during a disaster or crisis. In some areas, for example, the location of the facility and the type of event in the community may require that the hospital act as a shelter or support to the healthcare system needs. Here I would also highlight the contingency plans for basic infrastructures that we mentioned, water supply, energy. And for all of these items, I will highlight that we have international standards, local guidelines, and so on that can be applied or making as a reference. So we spoke now about the built environment that we saw in two perspectives. One, it's a wider and broader aspect of the built environment, that it's the environment outside of the facility, but we know that that influences also the inside and the patient and the visitors and the staff and etc. And we look to the inside of the built environment, so the built environment inside the facility. We spoke about this safety risk assessment and also the built environment conditions that are much related to codes, standards to achieve a standard of efficient activities. Now, if we move forward, I would like to do some considerations. We can move forward to the next slide. Thank you. So we have seen that WASH refers to the provision of water, sanitation, hygiene, waste management, and environmental cleaning. And there's the table from the Joint Monitoring Program. So that's the UNICEF and WHO, GMP. And we also, on the healthcare system, we have different levels of care. And each level of care as a different type of hospital or facility. And this also mentioned there's for different level of care, there's a different level of WASH, different level of expertise. I would put that way. So this is just to make a reflection how we are in the healthcare system, different levels of care, different typologies of hospitals according to the specialization. Here probably mentioned that the primary care normally the major order services require special attention, maternity services, some sterilization of instruments, some sluice areas, and a proper disposal of biohazard waste, some anatomical waste also. When we move to secondary and tertiary care, we start to have probably additional requirements of the water conditions and treatment, because we start with laboratories, morgue, maybe a small OR, operating theater. We could have some hemodialysis, dental services, endoscopy, the contamination washers or clean sterilizers, analyzers. So this now require a different attention on the water treatment, or the water that's going to be used. And in specialized service, probably mention nuclear medicine, specialized labs, specialized equipment, the use of chemicals and radiation requires certain quality or high purity water. Also, the need of certain type of treatments, in this case, ultraviolet disinfection, reverse osmosis, and so on. So we see more healthcare facilities, more complex and demand on the WASH system. And I would like, just as probably the last slide, that I will put some considerations. Probably here, I would like also to invite the other panelists to do some consideration, general considerations, because I have spoke a lot about the healthcare planning, the process, the strategic planning, how this is in a bigger, broader view. So strategic planning from a country or regional to the planning of the hospital, then to the planning of the facility, the importance of some items such as the brief of designing the hospital, the requirements that will be involved, And those requirements define the built environment, things like this, the IPC, so safety issues, policies for infection control, moving the patient, and so on and so on. So now moving here to some considerations, I would like to mention a few things. So infrastructures as a shelter from climate hazard, building better resisting construction systems, disaster mitigation, and also the infrastructure to provide quality care. And here we have the accessibility of water supply, clean and safe sanitation facilities, and hygiene points of care, toilets, appropriate wash disposal system, and so on. So we are looking to two different things. One is the infrastructure itself and build in a proper way so it can be a shelter. On the other side, it's the quality of the service inside, and now we are including the wash on it. Also would like to mention the lack of compliance with guidelines and standards, monitoring and technical expertise, so approvals, the local statutory agencies, municipality regulations, and environmental authorities. That this is, I'm just bringing as consideration, but this is becoming an issue. So those type of approvals, that things that should be approved, the standards, the compliance with standards, we already also spoke about this. So if the standards, code, guidelines, best practices, and protocols are there to be used, we are continuing to see healthcare facilities struggling in complying with the proper wash in healthcare facilities. And many of those difficulties could be improved. But I will not talk more about this because I wanted to talk first about the built environment in healthcare infrastructure. I will stop here. So the next slide is practically the end of it. And I'm open to any questions and considerations and discussions. Thank you.
Well, thank you, Mr. Fedor. This has been, and I see even comments in the chat, an excellent, excellent overview of the major issues in healthcare facility planning, built environment, and all of the considerations. This is such an important opportunity for us, especially who are not architects, to understand all these different issues and all of the building blocks and safety components that you talked about. So this has been really helpful to us. So we really do thank you for this rich, rich presentation. I would like to move to the panel discussion, which is also part of this, and introduce some of our other speakers and panelists that are inclusive of Mr. Fedor, our main speaker. We have joining us Agnes Aumo from the Ministry of Health, Department of Infrastructure, Uganda. We have Mr. Andreas Bold, who is a construction specialist in several different organizations and spaces. And then we have Mr. Randy Ramirez, who's from the Ministry of Health, Department of Infrastructure of the health area of Quetzaltenango District of Guatemala, where he is an infrastructure technician, analyst, and risk control specialist. So again, we thank 3 additional panelists who will join us. And so I want to begin by first welcoming you all, thanking you for joining us, and then asking you, if you would, spend about 1 to 2 minutes, because I just gave your name and your title, but tell us just in 1 or 2 minutes about your experiences with hospital environments and Washington healthcare facilities in your particular space. So Mr. Fedor, I know in the very beginning you introduced yourself and told us a little bit about yourself, but we had some new people come in since you started. So can I ask you to go first and just in 1 or 2 minutes, talk about your role within UN Habitat, and then we've heard about your experience in terms of your role as an architect, but just let us know a little bit about some of your work. And then we'll shift off to the other panelists. Mr. Fedor?
Sure, thank you again for the opportunity. So as I mentioned, I'm a healthcare architect and hospital planner, and it's more than 50 years that I'm in this professional, and I'm implementing and monitoring projects in different parts of the world. I've been working in Italy, Brazil, Trinidad and Tobago, Mozambique, also working closely with ministries of health, especially in Mozambique and Trinidad and Tobago, to include some of this or to improve some of these standards that we have been talking about. So in healthcare facility. And in Mozambique, particularly, we are approaching two different sectors. So one is the primary health sector, where, of course, as I mentioned also in my presentation, of an health, a primary infrastructure, it's completely different from a specialized infrastructure. So we are seeing these two types of infrastructures here in Mozambique: primary healthcare facilities, but also specialized. And we are trying to improve that in conjunction with the community, with other stakeholders, and the Ministry of Health. So practically, this is what I've been doing the last 15 years. Thank
Great,
you.
thank you. Thank you so much, Mr. Bador. Can we have Ms. Alma please introduce yourself?
Yes. I'm called Alma Agnes Kovia. I'm a medical engineer working with Ministry of Health, and I've worked with the ministry for over 20 years as a medical engineer, and really I have experience which I've come across. And I first give our thanks to our development partners, WHO, UNICEF, UN, because really they have pushed. If you come to Uganda, people now are trying to sustain because they have equipped us with a lot of piped water, boreholes, water tanks. And even now we are training people, and this is under WHO. We are training people how to sustain, how we can stay safe, how we can keep away from contamination of diseases when we keep washing every time, when we keep our theaters very clean. And all this, if the theater is not well washed, disinfected, patients tend to get sepsis. How we can use these autoclaves and we clean our instruments very well before we autoclave them, and even after autoclaving, how we can keep them very safe, and really even washing the equipments. If the equipments are not well stored, all this, we are wasting time. The lifetime of the equipment will be shorter, and even the person will overstay in the hospital because he has been contaminated with different sicknesses. So Ministry of Health is doing a great job here in Uganda, because for us, we send a technical team to go and do cut-out assessment. We assess connecting the new constructed facilities. Even we do when we look at the sanitation, like this shelter, do they have ACC? Do they have the ventilation? Is it okay? Because this is a place where we get a lot of people when they are doing surgery. Is our doctor safe? Is the equipment safe? And is the patient safe? So even user training at the end, because if we are going to construct, infrastructure is all about the building, the equipment, the oxygen plants, the IT communication system, as the discussant, he presented it on the floor. But then we have also to play a big role with our water. You people, you are giving us. What is the use of this water? We need distilled water to use in the autoclave. Because if we don't use distilled water, it's going to clog. And you remember the element will not work. So you see, it's it becomes more expensive to repair every time. Even you may lack money for spare parts. So really we thank WASH, because really it's of great importance to our country, and we have embraced it. And we really also urge our partners, if we urge for more support, because WASH should involve engineers right from the planning process. Because when you are planning, we have to know, this is how we lay the structure layout, as the architecture was he mentioned, right from the architectural work. We need to plan all together, the civil engineers, the architectures, the biomedical engineers, where the equipments are going to sit. And really, we shall make this world a better place. So even when you talk about infection control, disinfecting, incinerators, How are we doing this installation work? How are we transporting our infection things from the lab, from the theater, the transportation mechanism? It has to be a closed thing because these are highly infectious garbage whereby anything can happen at any time. So I thank WASH and really me like I didn't get time, like they conducted me, it was little time, but I thought, okay, I'll travel back to Ghana and present because really is a field where I've been like it's a field where I've been, and right now we always like do a baseline, developing specific costed plans, proposal for the funding for government and for partners. We urge you to help us in this. And really, I thank you so much. Let me give time to others also to contribute. Thank you.
Thank you, Agnes, and thank you for that introduction to let us know what you've been working on. We're going to come right back to you, actually, when we hear from an introduction from the other panelists to ask you specifically about your work within the ministry and how they go about some hospital improvements. So thank you so much for letting us know what your main focus and concentration has been. I'd like to turn to Mr. Bold, if you would just take a few minutes, 1 or 2 minutes, to introduce yourself and let us know about your experiences.
Hello, everybody. Thank you for giving me the opportunity. By profession, I'm an architect, and I was working the last 1.5 decades in various countries on reconstruction projects, mostly for Red Cross and other NGOs, and after earthquakes, mostly after earthquakes, in order to rebuild infrastructure which has been destroyed. When it comes to healthcare facility, there were several reconstruction programs. We did supply some healthcare infrastructure, mental clinic, reconstruction or refurbishing of a primary healthcare unit. And I would like to focus on my experiences. I did the last for 4 years in Nepal after the earthquake, where we built in a program to rebuild destroyed healthcare facilities on the lowest levels in various remote areas.
Great. Great. Thank you, Mr. Bold. Okay, can we have Mr. Ramirez, if you would please go ahead and take 1 to 2 minutes and tell us about your role and some of your experiences in WASH in healthcare facilities and built environment.
Hola a todos.
Hello, everyone. My name is Andres Ramirez. I am an architect by profession. Currently, I work in the infrastructure department of the Ministry of Health here in Guatemala. Our role in the department is to verify that all buildings meet minimum standards for health. We're always seeking ways and to try to make sure that these buildings have the ideal and appropriate capacity and that they will always help to serve people. Unfortunately, in our environment, we are a country that lacks many technologies and infrastructure of a good quality. And we as a department are trying to find ways to improve the quality of the health services we provide. We always have liaisons with different Congress people or governors, municipal mayors. We're always in constant communication with people in the different communities and villages that don't have healthcare services. We're trying to provide health to the most remote areas where people can at the very least get adequate services. And currently, we are trying to find ways to improve these services. So we want to try to find the best quality and the best ideas so that we can move this forward and provide these people with adequate services.
Great, thank you so much, Mr. Ramirez, and welcome again to all of the panelists. I am going to start this part of the session with a question to each of the panelists that's relevant to their perspective as well as their role. Other panelists can feel free to share reflections on any one of the questions as you desire. And then after we conclude the prepared questions, we will open the floor to the community, to you all, to engage with our panelists. So please go ahead and start putting your questions or your reflections in the chat as we move through this first section, and then we'll get over to the open floor as soon as we can. Thank you so much. So again, I'll start with Ms. Alma. Thank you so much again for sharing during your introduction your focus on environmental cleaning and medical equipment processing, as well as the importance of this for surgical theaters and other important spaces within a healthcare facility. But I'd like you, if you could, just take a broader view for us. And can you speak a little bit about healthcare facility infrastructure improvements and how you go about this? What is the process within the Ministry of Health Department of Infrastructure? How does WASH fit into your process of improving healthcare facilities? If you could speak on that for just a moment or two. Thank you, Ms. Oma. Oh, Ms. Oma, did we lose you? You're on mute.
We thank WASH because it enabled us to have clean, safe water, because you can have water which is clean and it's not safe to drink. Then also it enabled us like to get open, like to have piped water, boreholes across the health facilities, and even water tanks. We thank WASH because of WASH, it has made the health infrastructure like to be very clean, and in the planning like remodeling of these kind of facilities, because at first we had even facilities without sinks. Like if a patient goes, the hospital cannot even wash the hands. But now because of WASH, when a patient enters the hospital, you first go and wash, then you can go and see that doctor. And they encourage them every time, like, please go and wash your hands. You are in a dirty environment. So this, because of WASH, people have gotten enough experience, even like Corona here, it wasn't so much because every time people would wash. We had a lot of adequate water, really, like people would wash, and this is because WASH had come in as a project. Because of WASH, even our theaters, like, people are now able to work in a free conducive environment, because we even got support from UN, like we got 300 AC. Every theater was given AC, ICU AC, and even the laboratory AC. And this is where we get this high infectious kind of things. So even like also when we came to talk, when we look at our medical equipment delivery, the service delivery now is okay, because really we have space, and also the equipment's like they stay longer, because when we disinfect this equipment, look at like a suction machine. After sucking, those tubes, they clog the backflow of the blood and mucus. If you don't wash, you cannot use it again. Instead, you will be transferring the sickness. So because of WASH, we appreciate this, like, and also our health, the end users, these nurses, now they have embraced WASH. They can sustain, like we look at the sustainability. Here in Uganda now, we only have health center tools now, where we don't have the water tanks. And here we don't have doctors, like someone can be admitted. It's just a community health care where someone just goes to pick tablets and go back. But whatever this admission, WASH, we have embraced it. Everything is fine. And people are happy. We are able to wash our linen using the washing machines because we have adequate water. Initially, like you would pack clothes there, like the theater linens, there's no water. But the machine also, it could make a half cycle, because there's no water, it cannot run, it will automatically stop. So we thank WASH because first of all, it has improved on our health infrastructure of delivery by remodeling of this infrastructure. The current ones, they have been remodeled into good, bigger rooms to accommodate our equipments and the patients plus the health partners.
Great, thank you so much, Ms. Oma, telling us more about some of the work, and it looks like the assessments that have led to some modifications within several facilities in Uganda. I'd like to turn over, if you will, now to Mr. Ramirez. You, in your introduction, talked with us about some of the different actors that you engage with at the district, community, national level when it comes to healthcare facilities. Can you tell us how you oversee Washington healthcare facility infrastructure upgrades when it's time to do upgrades? Can you tell us a little bit about that?
Claro que sí.
Of course. Good morning or good day. Basically, from our department, we are a piece that is between the patient that arrived to the healthcare facility and the Ministry of Health, who is providing the service. When we go and check out the healthcare services, our contact is directly with the people who live in that community. We always check that they do have at least the basic services, water, energy, adequate income. We are working based on the law that was implemented by our government in 2016, where we state that all current services must be able to provide what would be considered adequate services, hygienic services with washing in the clinics, that the areas where women will be giving birth, they need to have a hygienic area free of viruses, and that at least you have environments where after giving birth, you have distant areas that have adequate at the minimum level, where at least there is a bed where they have the time necessary to recover after giving birth. Currently, when we are verifying the improvements in the different buildings, right now I have hundreds of services under my care. We try to check which are the infrastructures where it would be easier to improve. Sadly, out of these 148 services, many of them really do not have access that will work for people. Many of them do not have water. Out of this 80%, I would consider that maybe only 5% has drinking water out of their water taps. So every year we're fighting, trying to see that the quality and the improvement in our services are taking place. So we have conversations with the mayors of the different communities. We have relationships with the representatives, so we are able to get more financing to improve the services. Right now, I've been working 9 years in this field, and we have been able to improve 6 to 10 services that were working at the 5%, and we have been able to improve to 90% of the necessary service. This is hard work. We are still need to work with more than 100 places. We hope that in the future, we will be able to have the best quality for our patients, which is basically our objective, what we're working for. Thank you.
Opportunity to meet Ingeniero Ramirez. I'm from Guatemala, but I need to ask him, how can I contact him? ¿Cómo lo puedo contactar, ingeniero?
How can I contact you, engineer?
Claro que sí.
Sure. You can contact me at my phone number or my email address. I'm going to write it down here on the chat so we can be in contact forwards. Eh,
Soy de
Right.
Guatemala.
Thank you, Celia. This is what this is about. Connect, share, and act. So thank you so much. And thank you, Mr. Ramirez, for your response regarding how you have done, as you say, the hard work
Gracias.
of making improvements in Guatemala. Thank you so much for that. I want to turn to our other panelists.
Thank you.
Mr. Bold, if you would comment for us as someone who's coming from the WASH perspective, how do you see WASH fitting into broader infrastructure efforts within healthcare facilities?
In the work I was involved. Okay. These slides, they give a short overview about the work we have done so far in for TDH, in Nepal. So it's very interesting to allocate. This is now the physical implementation on the ground in various locations. The Ministry of Health, they were working on guidelines. They had some types from the very basic health facilities until to the district and to the various hospitals on various levels. We see this is a type D, which is the lowest, the smallest healthcare facilities, which is according to the government's Ministry of Health policy. These health posts are providing the basic health services in various communities, usually preferable in a distance of maybe, let's say, every 6 to 10 kilometers. And delivering the basic health service. So there's an outpatient, a clinic room, there's an administration, and an enlargement with a delivery room in order to create a safe space for mother and child during the most critical time, and with all the required additional services. So the templates were produced by the Ministry of Health, and TDH's contribution was in to modify and to strengthen the structure when it comes to seismic stabilities, considering that the buildings are withholding any seismic impact in the future, and to use the funds most efficiently. So to create on a reduced footprint to create space for all the required services to a maximum level. We see these two-story buildings which provide the healthcare services on the ground floor and provide space for staff on the first floor. With this, we do have a 24/7 opportunity to run staff. It's always there when it comes to delivery, and all the services are available. We do see in the small and in the layout that the whole area is fenced off. So with this one, it's cut off from outer impact. It keeps it's possible to keep the actual site of the health post clean from passing animals. We have a building which is visible on the layout as the core building, and on the back side we do have all these infrastructure which is required to ensure proper services. We do have a spring water tank, rainwater harvesting tank. We do have a hot water created by solar, as solar backup to charge batteries in order to provide electricity during power cuts, and the various parts which are required for either storing or the waste management. There's a placenta pit in a used in a suitable area, and then the soak pit and the septic tank. So all these, the infrastructure plus the services are arranged according to the available plots in the various communities. Next slide, please. We see the building itself with on the first picture, top left, with on the ground floor, the clinic services, first floor, living area for staff, and then the infrastructure with the rainwater, spring water tank, solar panels for electricity, hot water, and this overhead tanks. The building itself provides some area, waiting area in front of the building, which is shaded and protecting from sun and rain, which provides space for communal activities, for gatherings. On the upper floor, the picture bottom left shows the area which is staff, which provides some space for the staff. And on the bottom right, the various garbages for the collection to split waste and then to be handled according to the guidelines. Next slide, please. The facility is following the government's template or provide the spaces on the entrance, top left, which is the administration. Then it's a hand wash basin for people arriving, that there's always available hand wash facilities. Top middle, it's the outpatient room. Here again, there's always a hand wash basin in order to maintain the level of hygiene. Top right, it's a picture of the delivery room, which provides from the materials easy cleanable epoxy coated ground floor. We do have a proper skirting, which makes it easy for cleaning. Washable wall coatings here as well. Hand wash basins. Medium left, we see the connecting area from the entrance to the delivery room. On the right side, it's a scrub basin to provide proper cleaning before. We do have on the left side staff toilet. Central picture, it's the post and antenatal bedroom with access to accessible bathroom for the women staying temporarily at the health facility. Right side shows an autoclave area which is accessible from the central corridor, an autoclave area which provides cleaning for sink and electrical outputs for the equipment. The picture on the bottom right shows a sluice area between the delivery and to the outside, where first cleanings can be done after having given a birth. Then to maintain the hygienic level with the staff as well, the bottom pictures, center and left, show the staff quarter area, so that to provide to the staff equally hygienic living conditions with access to cooking and bath facilities. All bathrooms are equipped with a grab bar, with flushing cisterns plus sprays in order to match with the cultural use in order to clean. And to make it easy for people with different abilities. Next one.
Mr. Bold, if we can ask you to take 1 or 2 more minutes because we're nearing our
Yep.
time.
Yeah, and then we see we had a type D, so which was the smallest one, and then according to the location and according to the community's requirement, this type was adjusted in order to provide to cover the community's needs to the best. So we just see this one, which is quite different, which provides more services, always based at the access to the necessary to the wash facilities are ensured. Next one. Here again, bottom left, we see the wastewater disposal, soaking, the provision on the top left of again rainwater, spring water, plus hot water and solar. Next one. Is as well to transfer the template, the government's template, into according to the needs and the requirements of the community, providing access to all the services according to the available space, according to the topography of the location. Next one. But at top left, we see the rainwater collection as a small detail to use the available resources most efficiently. Next one. A few words to the area here as well, bottom left on the ground level. So using the circulation as gathering area, protected from sun and rain, where people may wait until their turn, or to use these spaces as well for trainings, for information of the communities. Next one. Again, a different layout, but all the available the access to the facilities. Top left, it's the area before the delivery room. There's a scrub basin. The delivery room on the bottom with the same surfaces to make it easy to clean. And the various bathrooms. Next one. Thank you very much. So this was just a short overview about the work we've done in Nepal in order to translate templates from the Ministry of Health together with the needs of the various communities, and to increase to reduce these on the smallest possible footprint, and to provide all the services to the best possible level. Using resources like electricity, water, and to ensure the health facility may be operated even during electrical power cuts during droughts.
Great, thank you, Mr. Bold. We appreciate the presentation and just showing us just the breadth of the work that you've been doing in healthcare facilities and all the different, again, options and considerations for different healthcare centers. Let me just acknowledge that we have reached to almost time, but there are several comments and questions in the chat. If the panelists would go ahead, I see Mr. Ramirez has already uploaded some guidelines from the Guatemala perspective. Mr. Bold, Ms. Oma, if you would also take a look at some of the questions regarding detailed guidelines or recommendations that you may have access to that you could share, that would be great. I did want to turn to Mr. Vidor for one last question, if we can squeeze out a comment for in 2 minutes, Mr. Vidor. We had from George Yap, if George is still here. Can you mention how environmental impacts of proposed wash infrastructure are considered? Meaning, are some formal environmental assessments or studies mandatory? Mr. Vidor, if you could just quickly comment on that question, that would be great, and then we'll close out.
Sure. Yes, there are some guidelines and also requirements. And I would just want to make mention to, there's one thing that it's the international guidelines, and someone asked on the chat also if there are other guidelines besides the FGI. So FGI guidelines are the healthcare guidelines for design and construction health facilities from the American Institution of Architects. There are different models. What I wanted to mention, it's when we apply international guidelines, and it's a very good practice then to have a benchmark, and then from there we know we have a standard. Of course, we have to deal with the local practices, local requirements and needs, the community and so on. And I think Andreas explained very well on this project. I also want to highlight 2 or 3 things. So the work that we're doing and combines, aligns a lot with what Randy Ramirez is doing, and also what Agnes spoke about. So when we have these primary health facilities located remotely, and in case of Mozambique, located also in areas that they are fustigated by natural hazards. So first of all, to have the facility as a shelter, it's a great improvement for some communities. The heading the wash in the healthcare facilities, it's a plus. So one of the new politics and agendas of the country, it's to include the wash in all public services, including schools, healthcare facilities. And I think that advocacy here, global advocacy from WHO, UNICEF, and also your institution to include the wash in healthcare facilities, and especially to have financial institutions applying and introducing this, it's a plus for our countries. And here I will extend my view and align my thoughts with Randy Ramirez. But one thing is, so we have the infrastructure that we are building back better, resilient to the hazards, and now we are including the wash. But of course, we need now operation, maintenance, skilled staff, spare parts, and all of this becomes an issue that we are seeing that it's current in these situations. And we are still talking about primary healthcare facility, rural areas. Someone also spoke on the chat or asked on the other infrastructure. So when we move to other infrastructures, then actually when we were talking, me and Lindsay, during the previous week, when we talk about larger infrastructure, actually we have a different approach. So we don't talk about wash anymore, but we talk about regulations for water, sanitation, drainage, water treatment, sewage, and so on. And I would like to probably underline and see also what are the other panelists' thoughts on this. So when we have bigger infrastructures, we have regulations, we have codes, and actually we have a bigger financial also approach. And there are consultants, probably there are contracts in the FIDIC type of contract. So you have a FIDIC engineer on board, and all of these make sure that whatever you're building, and because you're spending a lot of money, it's according with the regulations, with standards and codes. Even if you don't have locally, those type of contracts go and get higher contracts like FIDIC, as I was mentioning. It's an international type of contract. But when we move to these smaller facilities in rural areas, most of the times we see that there's a lack of alignment. And when I in my presentation I spoke about strategic planning. So some of those strategic steps are missing, and we see, for example, the bids launched with no proper requirements in type of material, type of requirements for built environment, where the design also is lacking some of those issues. For example, the ratio of patient and sinks, or the type of sinks, the type of taps, and all these issues that it seems that it's a minor detail, but they are very important when we go and build, because they create variations, they create costs, and so on. So I just wanted to highlight this part. Thank you very much.
Thank you, Mr. Fedora. You landed right on time. And I do want to acknowledge, first of all, and thank all of our panelists and speakers who have taken their time out of their very busy schedules to come and share with the community. I know we have reached exactly the 10:30 mark here in Eastern Time. So I recognize if some of you need to go, but if our panelists and our speakers can stay on for just 1 or 2 more minutes, if anyone else has additional questions, and I know if the panelists want to make any final comments, we'd be happy to have them, but we also recognize that some of you may need to leave. And so we just, again, thank you all. Many people have asked for the slides, for some resources concerning this particular webinar. We will make all of that available as we do on our webpage. It may also go out through our newsletter, but again, we'll make sure that both everything you've heard from Mr. Fedor and some of our other panelists, as they are able to share, we'll make sure to post that up on our website. If Haley could drop that in there, you can just go and take a look at not only this webinar, but any of the previous webinars where all of our sort of archive exists right now. So thank you, everyone. We appreciate your participation. And again, I thank our panelists. And Lindsay has one more thing she wants to share before we leave.
Yeah, let me close this out here. So final notes for you all. Just a reminder, you can subscribe to get updates on events and resources. They can send us topic recommendations about what you want to learn about. Today we talked about built environment. Next week could be next session could be something different. And please feel free to nominate a success story or a resource you've developed. Someone just emailed me a new resource they would like me to share next time around. So certainly happy to have you share what you're doing. Just a heads up, we will be at the UNC Water and Health Conference. How do you measure success for Washington healthcare facilities? A working session on indicators. We will be talking about evaluation of programs. For those who are not attending UNC, we'll actually be doing this as our November event. So we'll have you all said you were interested in workshops and roundtables. That will be our November session. Is going to be a working session remotely. But if you're at UNC, please join us. We'll see you there Tuesday, October 25th at 8:30. And lastly, just a reminder, we have our website, washingtonhcf.org/COP, and that is where all the resources from today will be posted. I will also send a follow-up email to all of you who registered with those resources that Luis and Randy and others were mentioning. So I will stop it there. Thank you for staying 3 extra minutes with us. Super grateful to our wonderful panelists and speakers and to our interpreters. Thank you so much for all of your help making this a successful event. And we will see you all next time.
Until next time. Bye-bye. Until next time.
Bye.
Thank you so much.
Take care all.
Thank you so much. Thank you so much, Louis.